I will record. Okay, we're going to go on to the next phase. Just the second half of this recording will be available. So the second half of the talk today is fibroma and cellular fibromas and a few of the other fibromatous tumors. All age groups are more common in adults, and these are usually hard or very firm tumors with sometimes calcification. There is what's called Meigs syndrome that has ascites and sometimes pleural effusion that can oftentimes look like metastatic carcinoma and be very, very concerning, but is just simply associated with these fibromas. There are some that are very cellular and have mitotic activity. And of course, excluding fibrosarcoma is an important part of the evaluation here. These also can occasionally have rare sex cord elements. I've got an illustration of that later on. And then rarely they will recur. I have not seen any recurrent ones, so we won't worry about that too much. So here's a nice example, a circumscribed, firm, solid nodule. You see the interlacing bands of tissue, spindle-shaped cells, very bland appearing, not hyperchromatic nuclei, but they can be a little bit on the cellular side of things. The more fibromatous types are less cellular. We don't differentiate particularly the behavior between fibroma, cellular fibroma, or even thecoma, fibrothecoma. They're all kind of in the same category of a benign spindle cell tumor. One thing I will call your attention to, however, which I think is quite helpful, are these colloid type or keloid type collagen bands that occur in some of these tumors. Sometimes people get very concerned about this and wonder, is this osteoid or something like that? Well, these may calcify at times, but it is part of the sort of fibrosing process that is responsible for these tumors. Now, another feature on this same slide that can also be seen is what's over here at this edge. And as you see here, we have a little bit of a epithelial line space. Commonly, this is a mucinous tumor, but sometimes you can get serous type epithelium or tubal type epithelium. I believe this may have had mucin in it, but it certainly looks a little bit more likely to be tubal type because I think we've got cilia in this epithelium. But it's just part of the tumor, just lying right next door to it as an associated factor. So don't let that confuse you into calling it teratoma or calling it, some other type of tumor, invasive carcinoma or something of that sort. If you were to need immunohistochemistry, and I hardly can imagine when you would, these tumors are positive with WT1, again, SF1, FOXL2, but inhibin and calretinin are less useful. Occasionally, you'll get maybe a little bit of smooth muscle actin and some hormone receptor positivity if you were to do those stains. I think I would only be doing this if I was concerned about things like, well, could this be a stromal sarcoma? Or is there a metastatic history of some spindle cell tumor? And this could represent a metastasis. So these would be nice indicators that this was primary in the ovary. Now, thecoma is really, I think, the same tumor, but has a functional capability. Clinically, they have the same scenario, same mixture. And there are the other terms that have been used, like luteinized fibroma if you find luteinized cells and so forth. But these can be a source of estrogen production that can lead to things like endometrial carcinomas and so forth. So identifying them and identifying their functionality is useful. So as I've mentioned, they can produce endometrial proliferations. Again, the same immunohistochemical profile that we've seen with the other tumors. Here's a gross image of one, and note the yellowed color, which would be more characteristic of a steroid-producing tumor, very bright yellowish appearance. With that color, you might again think of granulosa cell tumor or maybe steroid cell tumors as well. So the color is not totally specific, but does suggest that it's making hormone. So here's an example of a fibrothecoma. We can see these dense rounded nests of very cellular tissue. And it's got a lot of cytoplasm to it. And in this situation, we would look around to find some of the more luteinized cells, which are oftentimes these more epithelioid cells with a bit of abundant pink cytoplasm. Let's see if we can find some others around here. So here's some here, a little bit more epithelioid appearing. And sometimes you'll find them at the periphery of these lesions as well. Like here's a few right here, nicely luteinized, abundant pink cytoplasm, rounder nuclei, as you can see here. Fibrothecoma with luteinization, luteinized fibroma, or just thecoma, all are perfectly acceptable terms if you've got these nice luteinized cells that are hormone-producing cells from this small tumor. Now, I don't know why in this case we seem to also have a little bit of pigment in this tumor. Whether this is hemosiderin or melanin is not known. Some of these tumors will produce a little melanotic pigment. They can be positive with MART1, for example. Yeah, here's more of the luteinized cells here. So just like kind of a little gem that sometimes goes along with endometrial carcinomas and should be identified and recognized. Now, I mentioned that these could have minor sex cord elements in them. And here's an example. This is a fixed image, obviously, but you can see that this is little tubular type structures, maybe a little central eosinophilic body in some of these. These would be minor sex cord elements in a fibrothecoma type of tumor. Just to remember, there are a number of these other tumors that can have sort of focal fibrothecomatous type of areas. And that can include metastatic tumors like stromal sarcoma or metastatic gastric sigmoid ring cell carcinomas. Some of the Brenner tumors can have a very fibrotic background, and if you don't look closely, you could miss the transitional type epithelium. Here, I'll magnify this a little bit. And then some of the sex cord stromal tumors like fibrosarcoma, of course, could look very much like this. And some of these other stromal tumors as well can look very much like a fibrothecoma in areas. I'll show you some examples of both these two, and you'll be able to see some of the similarities. So differential diagnosis, of course, fibrothecoma, I don't differentiate those. Massive ovarian edema, that is certainly a very significant diagnosis to consider, and it's a benign disorder, but can look a lot like a very edematous and sometimes cellular fibroma. fibromatosis or just simple thecosis in a postmenopausal woman, stromal sarcomas, fibrosarcomas differentiated on the basis of mitoses per 10 high power fields. And then we've mentioned these others. The female or Wolffian tumor, female adnexal tumor resembling Wolffian tumors can also sometimes resemble this, although they usually have sometimes a mixture of a more epithelial type appearance as well. So the sclerosing stromal tumor tends to be younger patients. And this again is a stromal neoplasm, one-sided. It has a bit of a lobulated pattern with some cellular areas and some more myxoid areas. And again, it may or may not have some luteinized cells here. So immunohistochemistry is not specific for this tumor. I have a gross photograph here, which you can see is nicely sharply defined. Here's the cortex out here, and then the tumor is very distinct from the rest of the ovarian tissue. Note again that it's kind of yellowish, but we also have some edematous and pale white tissue in between as well. So here's a microscopic image, and I think you can see kind of this sparing of the surface with this somewhat lobulated, variable edematous and cellular tumor. Now, this is not quite as spindled as the fibroma or the thecomatous lesion, so it's a little bit less spindly. Having some of this vacuolization is helpful. And alternating areas where you have very low cellularity, as you see here, that are within the tumor, not just bordering on negative. So here's normal cortex out here. We can see the distinction. Doesn't have a really sharp border, but you can tell here we're not in tumor, here we're in tumor. So somewhere in here is the transition. And these lobulated areas, a little clustering around vessels sometimes, the sort of foamy, vacuolated appearance of the cells, and then the intervening areas that are less cellular. So I've only seen a handful of these, 1 or 2 cases. It's not very common. And here you can see in an image kind of the alternating edematous and more cellular areas. Now, is the differentiation from fibroma or thecoma really critical? Probably not. These have a very benign behavior. And so if you haven't made the right diagnosis, but you called it a fibroma or a thecoma, no problem. You're on safe ground. But you want to make sure that it's not a Krukenberg tumor or some other disorder. Massive edema, also not a problem if you missed that diagnosis, because it's a benign disorder, as long as you didn't call it malignant or something else. So several things very innocuous on here, but the one big one to be sure of is a Krukenberg tumor. Now, hemangiopericytoma, I put on this list. This is an old slide. There is now a recognition that the solid pseudopapillary tumors that we see in the pancreas can occasionally occur in the ovary. And that's probably what has previously been called the hemangiopericytoma. So that's probably a mistaken differential there. Okay, so here's a gross tumor. And as you can see, this is not the solid type of appearance that we see with fibroma. This looks maybe a little bit like a granulosa cell tumor. We've got some more fleshy areas here. So, I mean, maybe it could be a carcinoma. And then we also have sort of this fibrotic stroma in between areas here. So this was a case that I learned a lot from. And this gross appearance, I think, is very, very useful to reflect on and think about, well, what would I be thinking of? I was thinking, could this be carcinoma? Could this be a sex cord stromal tumor? What could this be? Well, here's the microscopic image from this tumor. And as you can see, we have some follicular-like areas here, some nested areas here, fairly blue, with these intervening tissues in between. So I would be thinking, well, could this be a granulosa cell tumor, for example? Could this be something of that sort? Could it be some other sex cord stromal tumor? As we come into higher magnification, though, notice how distinctive this very prominent, cystic changes in this tumor. These are not called Exner bodies, though. These are just little microcysts. Here's cyst, 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 cyst. And then we have these other more macrocystic areas. Well, something like this might look like yolk sac tumor, perhaps. We would think about that as a possibility. And then little islands of it in the fibrotic tumor tissue areas. Here again, this very micro watery appearance, microcystic pattern. And then a little bit of these sort of hyaline fibrotic zones like we had in that fibroma we just looked at. So, is this a funny fibrothecoma? Is this a sex cord, is it a granulosa cell tumor, or is this something else? Well, it's something else. So here's one of the stains that makes this tumor distinctive. And I'm pretty sure that this is, you see here we have both a nuclear staining and we have cytoplasmic staining. So this is the beta Katanan stain. And that is not found in virtually any of the other stromal tumors in the ovary. So it's not a fibroma, it's not a granulosa cell tumor, it's something that stains with beta Katanan. And here is the WT1 positivity. So it is a sex cord tumor. It is a primary ovarian tumor, but it has this distinctive immunophenotype of being WT1 positive and beta Katanan positive. So this is an example of the microcystic stromal tumor. Oh, excuse me, go back here. So this tumor, this microcystic stromal tumor, has this very distinctive immunophenotype of being WT1 positive and beta Katanan positive, strongly positive, which to this point, at least, is a phenotype that is extremely specific and unique in this organ. So we'll come back to the H&E and take another look and let you see. One of the other features I would point out is the nuclei are really quite bland. I hunted and hunted and hunted, and I could not find a single mitosis in this tumor. That's not saying that there aren't any, but they're extremely hard to find. And although there's a little bit of variability, it really has a very bland appearance. So I was expecting, after seeing that gross appearance, to see a high-grade tumor or something more concerning. But this is, in fact, the example of the microcystic stromal tumor. So I think this is probably a good place to stop because I have quite a few Sertoli tumors and the other component of the sex cord stromal tumors to share, but I don't want to run overtime with you and interfere with your day's work. And so I think I'll save those for next month. But we do have some time for questions if you'd like to pose any questions.
Professor Hassel, so in granular cell tumor, is code 1 in WHO classification, but clinicians often consider it a malignant one and describe chemotherapy. And they usually ask me if it's malignant or not. So could you share your experience on the biology of the granular cell tumor, especially the adult granular cell tumor?
That's a great question, Dr. Han. And the granulosa cell tumors do occasionally have malignant behavior, but microscopically, we're not very good at distinguishing those who are going to behave well and those that are not going to behave well. So there really are not any microscopic features that can predict recurrence or aggressive behavior, as far as I can tell. There's some suggestion that there may be decreased ER expression or other sorts of features, but more likely it's advanced stage, rupture, and whatever other independent things are going on in that tumor. Now, in our circumstances, there are trials that look at using some sort of chemotherapy at the initial presentation to hopefully impact this recurrence rate. But if they have done if they've gotten a satisfactory resection, if it's a stage 1 disease, then oftentimes they will just follow those patients and make sure that they know to come back. But they will, they don't know how to pick out these ones that are going to recur and treat them any differently right now. So I can't really provide much help for you there. Now, I will say that there are some more poorly differentiated granulosa cell tumors, the more sarcomatoid versions, that probably you could classify clearly as being more likely to be aggressive and malignant in that category. And I don't have any examples of that, but if we think of, go back to the histologic microscopy, of all of these microscopic patterns, the sarcomatoid versions probably are the hardest to really be sure that they're a granulosa cell tumor, but also may be more likely to have aggressive behavior, as is the case in other organs.
So it depends on the microscopically, we only consider the sarcomatoid pattern is the management one. Is it right, Professor?
Yes, I think that's where I would put it. I would probably, especially if I saw more mitoses and I had evidence of granulosa cell in terms of inhibin or other positive markers, then I would be more concerned that it was going to be malignant. But I don't have a lot of experience with that subtype, so I just say that as likely conjecture, but I don't have data on which to make that
Yes.
suggestion.
Whether the tumor is often a difficult question with us because the clinician often ask us if it's a management one or not.
Yeah.
Yes.
It's in some ways, it's like the borderline tumors in the epithelial category. You know, this is probably best classified as a borderline tumor in terms of behavior. Some of them will be bad. Many of them will be no problem.
And on the presentation is also a difficult one with us.
Yes.
So in those cases, we often see the ill-defined cytoplasm. So is this right?
Yes, some of them can look very ill-defined cytoplasm, almost fibromatoid.
Yes.
But they can also have sort of that epithelioid look sometimes as well. So it's, but it's usually, they're not sharply defined epithelial cells. That is pretty clear. And the sort of pseudo-nesting or insular or trabecular patterns usually are not everywhere. Usually there's some other pattern as well that says, oh, this is a more diffuse granulosa cell type pattern.
Yeah, because you know, sometimes the collisional body is not apparent on the presentation.
Yeah.
Yes. Thank you.
Well, excellent questions.
Thank you, Professor. But by the way, can I ask you other tumor in soft tissue now?
Yes, certainly. I'll stop the recording and then we can talk about the other case.